Vanakkam. When you are preparing for your examination, you need to know the basics about instruments. I shall be talking about the instruments used in plastic surgery, but it is next to impossible to talk about all the instruments in a single session. We shall talk about a few of the important instruments under the headings of what is this instrument, a little information about it, what is it used for, how is it used, and are there any modifications of this instrument which are significant.
The commonly used instrument in cleft palate surgery is the mouth gag. We need to understand how this mouth gag has developed and how it has reached the stage in which we are using it now. An assistant of Harvey Cushing named Crowe and Davis, who was Cushing's anesthetist, worked on a mouth gag from an instrument maker's catalog with a tongue depressor and ratchet mechanism and developed what is known as the Crowe-Davis mouth gag. This mouth gag was introduced in England as the Boyle-Davis mouth gag. So the Boyle-Davis mouth gag is the precursor of the mouth gag that we are using for cleft palate surgery today. But it was Norman Dott of Edinburgh who constructed a mouth gag that forms the basis of all gags popular today. It was C-shaped, one side open, consisting of two parts. The upper part with the jaw hooks and the lower sliding part with the tongue blade. This mouth gag was easy to apply, easy to adjust, and very easy to maintain. It has got a lot of similarities with the Crowe-Boyle-Davis gag, as Norman Dott, a neurosurgeon, had also spent some time with Cushing in Boston. To this Dott mouth gag, Kilner added a spring coil around the top, that is the cephalad end, to hold sutures in perfect order prior to tying, and this he had developed because he had a habit of very neat and tidy surgery. So this was the Dott-Kilner mouth gag with the suture carrier. Now this has been an open C-shaped frame of the Dott-Kilner gag. This became a rectangular closed frame, and this was the Dingman and grab modification which was brought about in 1962. The advantage of this was, since it was a closed frame, cheek retractors could be added from the sides to afford better exposure of the oral cavity. But one of the major problems noted with this design was the lack of adaptability of the rigid rectangle to fit the irregular alveolus of the cleft palate. So it changed again. From the closed pattern, it opened up by removal of the central segment of the cephalad side of the rectangular frame, and this was done by Thomson in 1969. This small opening up allowed for more space to work on the anterior and central third of the palate and the alveolar ridge, and this was the Thomson's open frame Dingman gag. But this frame also could not accommodate the abnormal spacing between the maxillary alveolar arches in patients who had maxillary retrusion, collapse, or a protruding premaxilla. Millard and Slepian came up with the Miami device, which had adjustments on the side so that this gap that was formed in the cephalad end could be opened up or closed. The framework of the mouth gag was being constantly modified to make surgery more comfortable. The tongue blade, which is an important part of the mouth gag, also underwent modification. This was the tongue blade of the original Dott mouth gag, but the problem was, since it was flat, it could cause compression of the endotracheal tube. When the Boyle-Davis mouth gag was developed, the tongue blade underwent a change and there was a groove for the endotracheal tube and an opening there which could allow good visibility. In this way, there was no compression of the endotracheal tube. The next important modification came in the year 2000 when Somerlad and Mehendale modified the tongue blade of the Dott mouth gag to facilitate cleft palate surgery. This tongue blade had flanges on the sides to hold the tongue in place. This was removed, and this modification helped in the cleft palate surgery of small infants and patients with micrognathia and surgery under the microscope. There was also reduced risk of compression of the endotracheal tube. But to make sure that there was absolutely no compression of the endotracheal tube, Andrew Doughty designed a tongue blade in which it was totally split to allow the endotracheal tube to pass unhindered. When using it, this mouth gag is held with the left hand or the non-dominant hand of the surgeon, with the cephalad end downwards and the lower end with the tongue blade upwards. On the cephalad end, you can see two retractors with grooves. The outer groove is for the lip and the inner groove is for the alveolus. The skin graft handle that we use day in and day out is an important instrument that is often asked in the examination. We shall see how the skin graft handle has developed and the features of the skin graft handle that we are using today. We need to know a little about the history of skin grafting. Sir Astley Cooper removed skin from an amputated thumb and used it for covering a defect on the stump in 1817. Using the same principle of utilizing the skin for coverage of defects, Jacques-Louis Reverdin, a Swiss surgeon, reported in 1869 on the hastening of healing of granulating wounds by means of small, very thin detached bits of transplanted skin, which he called epidermic grafts. It was much later that he realized that these so-called epidermic grafts actually had dermis in them. He used this instrument for harvesting these pinch grafts. It would pinch up the skin and cut off a little bit of the superficial layers. The precursor of the skin graft handle that we use today was developed by Wilray Papin Blair in 1930. When this first step was taken, Humby added a roller to the Blair knife, and the distance between the roller and the blade of the knife could be varied by means of a calibration device, and this was the Humby Blair knife. To make the harvest of the skin graft easier, Humby added an apparatus which would compress both proximally and distally and flatten the skin, and 2 years later Humby modified his own instrument and called it the modified graft cutting razor. The next important step came with the introduction of the replaceable blade by Dennis Charles Bodenham for use in carriers equivalent to the standard Blair Humby knives. But the assembly of this replaceable blade was a pretty cumbersome affair. Hence came the next modification of easy mounting of the replaceable blade, and this was introduced by Braithwaite Fenton, combining modifications so that the instrument need not be dismantled to replace the blade. And there was one more modification in this, in that the adjustment between the roller and the blade was achieved by two knurled collars mounted on the back of the knife. And when a graft was taken, this rolling movement of the guard would create a tendency for the skin that is being harvested to roll up around the guard. To avoid this came the next refinement by Watson John in 1960, where he designed a knife with a fixed polished stainless steel guard and a simpler with more rigid thickness adjustment. This rod had no independent movement, either sliding or rotation, while the graft was being taken. When there was absolutely no movement of the guard while taking the graft, it was good and the graft would come well. But this movement of the rigid guard caused a drag. To overcome this problem of the drag came the next refinement by Cobbett, who designed a guard that could slide to and fro but could not rotate, and this he did by cutting a D section instead of a circular hole in the guard end. This way it could not rotate. So the manual graft harvesting was refined, but to reduce the manual work, significant mechanical advance in split thickness grafting by Dr. Earl Paget with his engineering co-worker George J. Hood was done, and a semi-cylindrical calibrated dermatome was developed. This drum-type dermatome, developed by Paget and Hood, was refined by John Davies Rees, who constructed a dermatome permitting greater accuracy and control of the thickness of the graft. And during World War II, a young American surgeon, Harry M. Brown, conceived the idea of a new instrument, the electric dermatome. Scissors are important instruments that we use day in and day out in plastic surgery, and the examiner may ask questions about the scissors. There are mainly 5 types of scissors we use in plastic surgery. the Lister scissors, the Mayo scissors, the Metzenbaum scissors, the iris scissors and the suture cutting scissors. The Lister scissors or the bandage cutting scissors have an angled tip with a blunt tip on the bottom blade, and it is used to cut bandages without gouging the skin. The Mayo scissors are thick scissors which can be either curved or straight and are used for cutting tough structures like ligaments. The Metzenbaum scissors, on the other hand, are used for more delicate dissection surgery. They are thinner and have a longer handle to blade ratio. As far as suture cutting scissors are concerned, there are two main types. The Spencer stitch scissors have a small hook-shaped tip on one blade that slides under the sutures to lift them before cutting them. This hook also holds the suture so that it does not slip off. The north bent stitch scissors are also used for suture removal. Micro instruments have now become part of the standard instrument set of the plastic surgeon. We need to know more about these micro instruments that are so delicate and that we use almost every day. Before we see the different micro instruments and understand about them, we shall first try to understand the basics about micro instruments. The micro instruments are mainly made of two types of material. They could be of stainless steel or titanium. Stainless steel is a steel alloy mostly composed of iron and about 10% chromium. Small amounts of nickel, titanium and copper also may be present. Carbon is a common non-metal additive in stainless steel. Micro instruments are not usually made with the routinely available stainless steel. They are made with what is known as surgical steel, and this includes 316 stainless and martinistic 440 and 420 stainless. Because of the precise nature of the work done using micro instruments, they are further processed by a process called glass bead blasting, in which a decorative surface treatment of components made of stainless steel and noble materials is done to give the micro instruments a soft satiny look and a non-glare look. Micro instruments made of titanium are lightweight, have high tensile strength, they are more flexible than stainless steel. Anodized titanium is corrosion resistant and they are usually colored and usually blue. Micro instruments come in different lengths. Usually, for surface surgery, less than 15 cm length micro instruments are required, and for deeper surgery, more than 15 cm length micro instruments are comfortable to use. You would have noticed that the handles of the micro instruments are sometimes round handled and sometimes flat handled. The round handled micro instruments are known as the Baracker design micro instruments, and the flat handled instruments are known as the Castroviejo instruments. Micro instruments are unique in that sometimes they have to be used for prolonged hours. It is important that they are balanced. This means that there is a slight counterweight on the proximal end of the instrument and the center of gravity lies in the web space between the index finger and the thumb for better feel, control and position. We shall see more about this later. When using micro instruments for long hours, it is important that we choose the correct instrument. Micro instruments can be either angulated or straight. In angulated instruments, the grip is perpendicular to the working surface, as in needle holders, so that there will be no obstruction of the view, and they are designed to facilitate needle driving through the tissue. In straight micro instruments, the grip is parallel to the working surface, usually used as passive support or grasp in the non-dominant hand. Now let us consider the commonly used micro instruments one by one. The micro forceps. Now these are the forceps. You will find that these forceps are what are known as spring loaded. That is, they are normally in a position of open. Okay, this opening must be about 8 to 9 millimeters. It should not be too wide open or too close. If it is too close, that means it's too tight, and if it's too wide, it's too loose. Now when you will note are straight flat handled, because you need to have stability when you are holding the forceps. Secondly, when the forceps closes, you should note that not only the tip must close, but it must be closed for about 3 millimeters. Only then you can hold the suture material there. Then how to test whether it is tight or loose. When you hold it like this, just pronate it. You can hold the forceps and just pronate it in the moderate position. If it falls, that means it's too loose, and if you're holding it, hold it in close position, and you will find that if after some time your thumb web starts paining, that means it's too tight. This is called balanced. When you're holding the forceps here, it is sitting on your thumb web, and the weight is more on this side. That's called balance. So you don't need any force to hold it in that position. Curved microforceps can also be used in routine practice. They are usually used for reaching under the vessel, for tying knots, and doing patency tests after the anastomosis is over. The vessel dilator is a modified forceps. In that you can make out the tips are very sharp and very smooth. Now they are tapered, the tips are tapered. Similarly, you must have an opening of about 8 to 9 millimeters. That's the ideal for the dilator. The dilator is also angled, you will note, and it is flat handled. It's angled also, so that you can insert this into the vessel and you can gently dilate the vessel. And this tip must not harm the intima that is inside. So this needle holder you can make out, this is again round handled, so that you can have movements. It can adjust to any direction that you want to turn the needle. And this is also curved, you will note, so that the plane of the grip is at perpendicular to the suturing. Then you will note here that there is a space here. When it closes completely, there should be a small gap over here. If there is no gap and it is very tight, this particular point, the suture will get caught into it. That should not be there. It should be open. It should not be too tight over there. These are the dissecting micro scissors. You can make out the curved scissors here, and the handle is round handled to allow good movements and manipulation. This being curved, the grip is perpendicular to the surface of action. These are the straight micro scissors, sometimes known as the Adventitia scissors. You can make out the round handle, which is important for giving it the flexibility of direction of action. The tips are very sharp and are used for cutting the Adventitia. They can also be used for cutting the fine sutures. There are many bone instruments on which questions may be asked in the examination. One of these instruments is the bone nibbler or the bone rongeur. These bone rongeurs are designed to chip, crack or cut away bone. A rongeur is a heavy-duty surgical instrument with a sharp-edged, scoop-shaped tip used for gouging out bone. Rongeur is a French word meaning rodent or gnawer. The first design of the rongeur was created by Dr. Robert Masters Kerrison. Bone rongeurs can be either single action rongeurs, where the fulcrum is at a single point, or double action rongeurs where the fulcrum is at 2 points. The advantage of the double action rongeur is that the amount of force required by the surgeon will be less. In any plastic surgical procedure, exposure of the affected part is very important. Self-retaining retractors play an important role in providing this support. Among the self-retaining retractors commonly used in plastic surgical procedures, the Gelpi retractor gives a good exposure, but the resultant exposure is diamond shaped and may not give access to the peripheral part of the access site. The Weitlaner self-retaining retractor is more useful in this regard, as it has multiple prongs which affords better exposure. However, in superficial areas where we need good exposure, especially for procedures like microsurgical anastomosis of the superficial temporal artery or the radial artery, we need a smaller self-retaining retractor, and the Alms self-retaining retractor suits the bill. I hope you liked the video. I enjoyed making it. Please click on the shown links to see more about the basics of the median nerve, anatomy,
and the clinical examination of the median nerve injuries. And do not forget to subscribe to keep connected with the latest in learning hand surgery.